Welcome back to Middle Fingers Up. I'm your host, Kieran McKay. Today, we are continuing an important women's health conversation, a conversation that often goes misunderstood and undiagnosed for many women, PCOS. This is what we're going to talk about today. And I'm really happy to have Dr. Hussain back today. She's a naturopathic doctor. She is a literacy advocate, author of the Period Literacy Handbook. And if you've been listening for a while, you may remember Dr. Ann from episode 107. She came on to talk about weight stigma in the medical field, the origins and misuses of BMI, and struggles faced by those who have conditions like PCOS and endometriosis. And Dr. Ann was also here with us back in episode 93 when we talked about what does a normal period actually look like. So she is the perfect person to come on today to talk to us about PCOS. She's been doing incredible work in hormonal health, period literacy, as we said, and advocating for more inclusive research for women of color. We are learning a lot lately. You go to social media and you learn a lot. It's so weird. On one hand, you're learning a lot about PCOS. And then on the other hand, maybe you're not getting enough info when you're wanting to go talk to a doctor about it. And so one of the things we're learning is that this isn't just about irregular periods or difficulty losing weight. It's a lot more complex as I read, as I talk to other women who have been diagnosed with this condition. It's PCOS is complex with metabolic, hormonal, and reproductive impacts. And I think you guys remember episode 2. 2 women came on, both diagnosed with PCOS, and were struggling with fertility issues. And that's a huge thing today, that women who are trying to have kids are learning in that sort of way, that they've been battling PCOS for years. And so I think the frustration for a lot of women, a lot of South Asian women, is the struggle to get answers or even know how to advocate in the gaps of the health system. And one of the biggest, I think, issues is the advice a lot of women get, which is lose the weight, eat clean. And I think when we talk like that, we oversimplify a condition that is influenced by genetics, is influenced by environment, can be influenced by systemic healthcare gaps. And then even, which we're going to get a bit into, is colonization. A lot of women of color are struggling with reproductive health issues that are dated back to unfinished business with our ancestors. And throughout the generations, we haven't been able to heal. So all of that impacts us as little girls growing up and going through the lifespan. And today the hope is that, we're not going to cure something, but we're going to continue talking so that women know how to advocate for themselves. Women and caregivers can look out for early signs for young girls going through this. A lot of this has to do with how can we support our future. So just getting a little bit more into this before we bring Dr. Ann on. I just want to say at this point, for some of the South Asian women that I've talked to, I think where this goes a bit deeper is that our reproductive health isn't just about us. It's linked to our mother's pregnancies. It's linked to the foods available to our communities. It's linked to rapid migration, lifestyle changes, and generational stress. And we're just starting to scratch the surface of how these factors impact our health. And I think another area for a lot of South Asian women is early on, you learn, whether you're taught this, however you learn hard that a little girl's goal and dream is to grow up and have babies, whether that's going to be her path or her journey or not. That is what we are told. And a lot of our reproductive struggles, there's not enough space to talk about that grief and loss. And when you're told you have to be one way all your life and you grow up and the impacts that has in your households and your community. And I'm hoping today's conversation will generate those deeper conversations in our friend circles and our group chats, and even with our doctors. So Speaking of our doctors, here is one of our favorite ones, Dr. Anne. Welcome. You're here today. Thank you for coming back. You're here for a third time. And I know a big part of this is because you have so much passion for women's health and particularly talking about PCOS and helping us with that. So thank you for your time and being here today.
Thank you for having me. I'm really excited to talk about PCOS. It's one of my favorite topics to talk about.
I know you're good at it too. Your Instagram, stories, your reels, you find such creative ways to reach out to a lot of us. I don't have any health issues with PCOS, but I'm learning so much because I know a lot of women around me that are struggling with this particular issue. So can we just maybe get a little bit into okay, so maybe before we get into the science, we can go to this little personal note of how PCOS, as you mentioned, it's a passion, how it's closely connected to you, and what brought you to this work. Maybe you can break that down a little bit.
Yeah, for sure. So I have a personal connection with PCOS because I have PCOS. At this point in time, I would say it's quite well managed, and it's taken me a long time to really understand it, and we're still learning more and more about it. Retrospectively, I can also say a lot of people in my family have had it, and they didn't know because it was not as well understood a few decades ago. And not just that, it's sometimes diagnosis can be hard, right? Like my mom grew up not here in Canada. She grew up in Pakistan, and over there, you don't really, like preventive health or proactively, you don't really seek out care, right? Like unless there's an issue or there's a problem. So, and then there's also cardiovascular disease in my family, and that is linked to PCOS in offspring, right? Like you were saying, there's the genetic piece, and the genetics sometimes don't have to mean that your mother had PCOS. It could also mean that there is diabetes in your family. There's heart disease in your family, like heart attack, stroke, etc. Right? Like there's a spectrum of heart disease and cardiovascular disease risk factors that are involved in that. So yeah, I have PCOS. I used to have really irregular cycles, and then started to get acne, like cystic nodular acne. And that sort of is what brought me to this work, and is also what keeps me sort of really engaged in it, because I have that personal connection, and I obviously like selfishly want to help myself, but also at the same time help other people. Most of my practice is PCOS patients, some fertility track, some perimenopausal, some like early on. Sometimes I get people who are already diagnosed. Sometimes I get people who are misdiagnosed, because there are a couple of diagnoses that look similar. And sometimes I get patients who are just wanting to know more about it, right? Like once you get a diagnosis, sometimes you get an oversimplified sort of, like you said, go lose weight and eat less, right? Like move more, eat less, or come back when you want to get pregnant, or XYZ, right? Like here's a pill. This is what's going to help you with your PCOS. And the pill can be really helpful for that. However, we also need to make sure we are understanding what exactly it's doing, just so we can make an informed decision, right? Like if that's the decision you want to make, great. But I think some people who end up on the pill, they don't really know what's happening. And then when they come off it, they're like, hey, my cycles are still irregular. And sometimes things change. So yeah, that's a long-winded way of saying I have PCOS, and I see a lot of PCOS, and the family history exists.
Thank you for that. I have a few questions about, you take the pill or you get off the pill and you're like, oh, I'm not aware. That whole I'm not aware piece, like if we go back to even for you as a little girl going through some of the symptoms, not knowing, your family not knowing, what are some things that can be going on for you, that you're maybe thinking, oh, something's up, or how come my friends don't talk about their period that way, or whatever it is a little girl like you would be experiencing, whether it's the acne or what are the signs that you started to notice before others did that something was going on, before anyone validated it or whatnot for you?
Totally. Yeah. I grew up with no menstrual health education. My period was a complete surprise because I lived in Karachi at the time. when I got my first period. So for me, my menstrual education really was my mom telling me that this is what happens every month. Here's how you use a pad, and she gave me some instructions for like a shower you do after your period is done, and that was it. I didn't know to track my cycle or anything. And then when I moved back to Canada to start high school, there was the menstrual education portion had been done, so I didn't get menstrual education at that point either. But what ended up happening was that I started getting a little bit of acne, especially when I went to university, right? Like at the beginning, I was really anemic, and I have thalassemia, which is quite common in people of Mediterranean, African, and Asian descent, which is like a genetic kind of anemia. So a lot of like my fatigue and other symptoms were always chalked up to my anemia and low iron and thalassemia. So it wasn't until I got to university and things started changing. So I started getting acne, weight went up, I was having some mood dysregulation, and then I went to the doctor and they gave me the birth control pill. And then I developed migraines, which I had never had before on the pill. And then I was in biochemistry, so I started doing my own research. In my family, we didn't really talk about periods or health. And at that point in time, I didn't really know what was normal and what wasn't normal. So I started by coming off the pill because I went to my doctor and say, hey, I'm getting migraines. Do you have another option for me? Or what else could be going on? And I didn't really get an answer. So I had the library, I had textbooks, and I had my biochem degree. And that's really what led me down the path of understanding a menstrual cycle, realizing my cycles were super irregular. And that's not a normal thing because that was my normal, right? Like I didn't have anything to compare it to. 90 days without a period, that's my normal. 45 days, 60 days, just unexpectedly showing up was my normal. And then when I came off the pill, I started getting more symptoms because to some degree, but that's what the pill does, right? Like it decreases testosterone, so you get less acne. It gives the semblance of a regular menstrual cycle because you're taking your 3 weeks of hormones and then you have your withdrawal bleed, right? So like in many ways, it's managing some of the manifestations of PCOS.
Yeah.
And then when I came off it, that's when a lot more symptoms started to show up, and then they progressively got worse, and my stress level got progressively worse, and everything sort of came to a head. And then eventually I found a naturopathic doctor, and here I am many years later, right? Like that's what led me down that road because I was on the road to becoming a cardiovascular surgeon.
Yeah, like such a thank you for change. Although what a link too. Like you know, if you think about it, go on the road to being a cardiovascular surgeon. And when we look at some of the stats and some of the symptoms or maybe correlations with PCOS and our health, there is a lot of health related to cardiovascular, our heart disease, blood pressure, all these kinds of things that play a part. So when you were growing up, you know, like many little South Asian girls, I think there wasn't the process. There's a lot of content, a lot of hygiene care, but there's no process about what this means for us. And so it's a lot of black and white, take it this way, take care of yourself. And a lot of us experience that, even with the, healthcare at school. And so how do you think we can change that conversation or shift that conversation as caregivers with our daughters and our sons, our children? Because everybody should know about this. It isn't just if you're a girl and you should know about this, especially if you're, a man and going to be enjoying a life with, women, whether it's daughters or friends or wives, right? Like, I think we're all around each other. And so this is important information for all of us. So what would you suggest, some things that could have been beneficial or that we can pay attention to with our kids today when it comes to PCOS health?
It's obviously a loaded question, as you know, because I think there's so many.
It's only kind. All loaded.
Because there's so many layers there, right? I think as a culture, sometimes we really, and I think this is a global thing partially, we shy away from uncomfortable conversations. but the only way is through, and we need to have the conversations. Like there's no real other way to put it. We need to have these conversations even through the discomfort. And when you, as a parent, let's say, or a parent figure, are having these conversations with someone who is either about to start menstruating or has recently started menstruating, I think like that modeling of working through a difficult conversation and even like calling it out can be so empowering to someone who also is feeling that discomfort, and calling it out right from the get-go. I think at least like that's how I work. If I'm feeling discomfort, like sometimes I'm like, this is really uncomfortable to say, but I'm going to say it anyway, because this is how we move through and learn. I might not get it right, but I do want to plant some seeds. And I think that's kind of what we need to do when kids are younger. And that's part of what's missing in our education system right now as well, is like the age appropriate education. We get a little bit of education in elementary school and then nothing. Poof, you're just supposed to like learn in the wild. And right now, these days, like the internet can be a wild place, as helpful and lovely as it is from an educational standpoint, right? Like there's just so much information out there. So I think like we need to have the conversations, and it doesn't have to be anything big, right? Like I think it just needs to start with even teaching or talking about, hey, how can we track your menstrual cycle, right? Like I feel like that's like an easy entry point.
Yeah, it's a task. Like it's if you can't process, it's an easy task to do.
Exactly.
Yeah, you see results. It's tracking is great. Okay. And you have a book that can help us with that.
Totally. Yeah. And tracking hasn't been easier before, right? Like it's so easy now. It's never been easier than this. But anywhere you can track anywhere. It doesn't really matter. Like I literally track it in my calendar because I can't be bothered to download an app and track it in there, right? Like I know myself, like it's just going to go in my calendar, and then I can just look back, just like swipe back to see
Day
the previous
one.
month and the month before. Exactly. Right. And then also teaching that, hey, it's supposed to be monthly, but in the first couple of years, it might be a little irregular. And I think it's also starting the conversation about like, hey, if there's something that's feeling weird, or if you have questions about it, bring them up, right? Like it's also opening that line of communication, which I feel wasn't there. There's definitely a lot of cultural barriers that I can speak to that were part of that, right? And also I also knew that my mom didn't know anything about it, right? Like just based on how she presented it to me, and resources at that time were different. We're talking about, how old am I? We're talking about like 23, 24 years ago at this point in time in Pakistan, right? So like, I think there's many ways to have these conversations, and really having them as a family, because ultimately menstruation affects everybody, right? And I think the way forward is to talk more openly about it. That's the way that we understand what normal is. We stop normalizing things that aren't normal. And we also get better care sooner rather than later. And even like early on, we do expect, especially in the first couple of years of menarche, which is the first period ever, we do expect and experience changes and like ups and downs. But if there's significant ups and downs, we can at least like give a provisional diagnosis, right? Like, or this is something we need to revisit in 1, 2, 3 years, plant the seed in the family unit. And I think these are all important conversations to have. I think there's no wrong way to have a conversation, really, for the most part. It's just we need to have the conversations and work through the discomfort.
Yeah, I think so well said for guidelines when we're parenting our children. And I think a lot of times we're afraid we're going to tell them too much, and it's not going to be said in the right way, and we're going to ruin our kids, and we're already doing that in all the other ways. So when it comes to these health issues, and I think we also have to give ourselves a break, because you made a really good point. Many of us are barrier breakers. A lot of us first generation, we're on the cusp. We're either part of that I don't know anything generation, or the okay, I have access to resources. I can learn how to find these things now. And I think sometimes we forget that when we're breaking barriers and stuff, we're doing something for the first time. So we don't really know. We don't really know what to compare to. And I think on one hand, that helps us sort of heal with our parents and our caregivers of like, they knew what they knew. And also, another point you made with our kids and, even our daughters, when we're teaching them about their reproductive system, I think sometimes as parents, and a lot of our elders did this, it's protection. So they didn't know maybe, but also we protect our kids, and we when we do that, what we're really not doing is the thing that we should be, which is teaching them a sense of responsibility for themselves. Like, you can only rely on yourself in this world, right? Like, you have love and support and all these things, but at the end of the day, you have to be the one to make a decision if you're going to get up or not. And I think we miss that when we're raising our kids or when we're growing up, because we want to care and love and give our kids all these things that maybe we didn't get. But responsibility is so linked to understanding, like, myself, awareness, and those kinds of things. And I think, having these conversations, eventually we get to that place. But if we don't start somewhere, yeah, it's never going to happen. And then you and I grow up, and, we thankfully, I went to mental health school, you went to doctor school, and, we come together and we can have these talks. But a lot of times it doesn't work that way. We're using the acronym, and I don't want to be disrespectful. Like, I don't want to act like I know it so well. So if we could break down what PCOS is, and maybe help us understand a little bit more of, like, what is this hormonal disorder, and what does it impact?
Yeah, so PCOS stands for Polycystic Ovary Syndrome or Polycystic Ovarian Syndrome. And it really is a misnomer of a name, because people think I have ovarian cysts, right? Like, and that means I have PCOS, but ovarian cysts are something different and polycystic ovaries are something different. So let's take a step back. Like, first, from a diagnostic standpoint, what PCOS looks like and what we're looking at medically is irregular cycles or anovulatory cycles. So in a regular menstrual cycle, we're supposed to ovulate sometime around mid-cycle, which is the release of an egg, right? So if we're having anovulatory cycles or delayed cycles are oftentimes a sign of anovulatory cycles. That's the first criterion. Second one is either physical signs of high androgens, so like male type of hormones, how we classify them, like testosterone, for example. So that could look like acne. So most commonly, we're going to see cystic and nodular acne. So quite severe acne for the most part, oftentimes along the cheeks, along the jawline, could be on the back and the chest as well, could be on the inner thighs, or hirsutism, so excess thick, coarse body hair growth, especially on the back, on the upper lip, on the lower abdomen. So again, like in that male pattern. That could also look like hair loss, pattern hair loss. So pattern hair loss typically is going to happen like in this part of the head. And so those would be clinical signs of high androgen levels, or you're going to have elevated androgens when we test your blood. So that would be elevated testosterone or androstenedione or DHEA. Those are the three hormones that we're looking at. But really, the clinical signs and symptoms is enough for us to make a diagnosis, along with the signs of anovulatory or irregular cycles, as long as we have ruled other things out. So PCOS is actually what we call a diagnosis of exclusion. So we want to make sure that we've ruled out all the other things that can mimic it or that can contribute to some of those symptoms, like a thyroid disorder, for example, can cause irregular cycles. Hypothalamic amenorrhea, which is when we're not meeting our energy needs and our body's in a stressed out state so much that our ovulation is shut down, can also look like like PCOS. And the third criterion, which isn't particularly relevant to anyone who's within 8 years of their first period, is polycystic ovaries on ultrasound. So this actually looks like immature follicles that have eggs in them that are in the ovary or an enlarged ovary. And that's why, and they're not true cysts, and that's why it's a misnomer, the PCOS. We call it a polycystic ovary, but really what it is small follicles that have eggs that aren't maturing properly, and they're not getting to ovulation because of the hormonal dysregulation. And that's what we're seeing on ultrasound, or they were present and now the ovary is enlarged as a result. Or elevated AMH. So AMH is anti-Müllerian hormone. Typically, we use it in a fertility setting as a marker of ovarian reserve. In PCOS, we see elevated AMH, which isn't a really true depiction of your ovarian reserve, because it's those immature follicles or cysts that make the AMH. So when you have more of them, you have a high level of AMH, but it's not really telling you about your ovarian reserve. So that's a long-winded way of like diagnosing, of saying how we diagnose it. But how it often looks like for people, and that's what I'll focus on, is irregular cycles, delayed cycles. And we're not talking about like 2 days late from your normal or like 3 days late from your normal. We're really talking about like over 35 days in an established menstrual cycle. It often can look like irregular bleeding patterns even, because that can be a sign of anovulation, right? Like if you don't ovulate, sometimes that you can have a spotty period, you can have a super heavy period or a prolonged period, or you can go 3 months without a period and then have just bleeding for a month. We're looking at that acne, hair loss on the head, hirsutism, or that excess body hair growth. We can see insulin resistance. So the dysregulation in hormones that is happening in the background in PCOS is insulin resistance. So this is pre-blood sugar dysregulation oftentimes. So your blood sugar is going to come out normal on blood work most of the time. It's that your body is trying harder to keep your blood sugar in that level. And then later on, that can look like gestational diabetes. Later on, that could look like full-on diabetes. It can also look like other heart disease, like people with PCOS do have a higher risk of heart attack. PCOS can also look like body dysmorphia, or can be related to, like, oftentimes there's a high prevalence of body dysmorphia, eating disorders, or disordered eating patterns. It can also look like infertility, higher risks with pregnancy. It can look like a lot of different things at the end of the day. It can, including like weight gain or difficulty with weight loss. I'm missing a lot of things here, but I'm sure we'll touch on them as we talk.
You covered more than the ones that I had jotted down as symptoms, so you did good, Doc. There's a lot, and I think when you list these off, I think this makes sense why it's so misunderstood and, hard to diagnose, because a lot of, other than some of them maybe like very specific symptoms like the hair growth and the acne, and maybe the weight gain or not, a lot of the symptoms have other underlying factors that could be going on too. And so then, we might be treating other things or looking at things. And, I've even, in that fertility episode, Stephanie had even talked about, because she wasn't a super, quote unquote, thin woman with an eating disorder, every time she'd end up in the hospital, they would never consider asking her or assessing her for an eating disorder, because for her, she lost so much weight. But for what textbook medical, as you're nodding, you get what I'm saying. And so there's so many things that are going on for a lot of young women and teenage girls. And the world has so much to do, like the environment has so much to do with this. Why do I have an eating disorder? Why do I care so much about my acne? Why do I care so much about, because we care so much about how we look on the outside. That's how we're rewarded. And so you can imagine what that could do for a young woman, as she's forming her identity and her self-esteem. And I think this is why, as caregivers, like we really have to break these barriers for the next generation, within our community, because as we're learning, we're also parenting a lot of kids. And I think we have to be more aware of like what is really going on for our kids when we're missing some of these pieces, not to make us feel shitty or guilty, but being a young kid going through adolescence is really difficult as it is. And if you get through that, you deserve an award. But when you're going through that as a little girl or a girl of color with all these, health issues, what is a thing that a lot of these women show up talking about? There must be something that they say in the office or what that can help answer what I'm trying to get to better, which is, the struggles with their mood, their mental health and all these things. Like when a lot of these women show up to your office, do you have like a theme of kind of like how a conversation goes, or a lot of unknowns or knowns that they show up with that have to do with, their identity, their self-worth?
Yeah, there's a lot to unpack there. So I think like in the younger population, because puberty and pubertal hormonal changes have an overlap with the symptoms of PCOS, it's difficult to diagnose at that point in time, 100%. And I say this all the time, even to clinicians, because I teach about PCOS a lot. And at that point in time, what we really need to do is give a provisional diagnosis, especially if there are risk factors in the family, and then keep an eye out on it and work on some of the things that we can work on, right? Like that's kind of what we do. It's usually like the parents that are more concerned at that point in time than the kids. The kids or the adolescents oftentimes are more focused on the acne, right? Like the resolution of the acne, or the hair growth or the hair loss on their head, whatever it is that they're experiencing, right? So, like, I think we need to treat the symptoms so that we can help support their self-esteem and then plant some seeds in the family unit. As people get older, there's a mixed bag of things that come up, but at the end of the day, PCOS is a full body condition and it's a multi-system condition, right? So oftentimes I'll hear about fertility and all the different things that come along with that, that can I get pregnant? There's a lot of victim blaming or like self-blaming also, because sometimes in the wellness space, we focus so much on individual health, right? Like, and that you have the power to do all of this thing. And sometimes when your metabolism and your genetics and everything that you've grown up with is like working against you, you internalize that and say, hey, I'm a failure because I can't lose weight, or I can't get pregnant, or I can't fix my acne, or I can't like out eat my condition, right? Like that's kind of that's a very common theme I get, that like I am doing something wrong, I am to blame, and I have to fix this. And I know we're going to talk about this a little bit more because I want to talk about the social determinants of health and how they play a role in that. And then there's like the self-esteem, the comments from other people. And we talked about this in our last episode on weight stigma. But in South Asian cultures, especially, just because we also are, that's the culture we are most around, commenting on bodies is the first thing out of people's mouths.
100%.
And that sticks, right? So like a lot of like body image distress, it also comes up with that, and a focus on weight loss, which is then propagated by medical doctors who either just say sometimes nonchalantly or don't diagnose an eating disorder, or they're just like looking online, and there is science behind like mild to moderate weight loss can restore ovulation, but it's not the only thing. And also like prevention of weight gain oftentimes is a good target for us while we work on other lifestyle habits. There's just so many layers to that. But yeah, I would say like the body image, the internalizing their diagnosis and all aspects of it, and like how they ended up here, and regret is a big one too, especially as people age and they're like, oh, I wish I knew this before, or I wish I had done something about this before. And I think we can all relate to that in some way, shape, or form, right? Like regret on something we know now that we didn't know before, which isn't really helpful. Like I get it, but it isn't really helpful, right? Because we only move forward from here, and we're constantly learning and evolving anyway, and our resources are changing all the time.
Yeah.
And our understanding is changing all the time. So those are some of the themes that come up quite often in my practice, at least.
I appreciate that. I think that was a lot of information that was very specific and helpful, and hopefully people can, kind of relate to and maybe even feel validated by, like, oh my goodness, this is exactly what I'm going through. Give me Dr. Ann's number. I need to go see her. Why does PCOS often get misdiagnosed or misunderstood altogether? I know you kind of covered some things, but like ultimately, and maybe we need to repeat it over and over, but there's lots of knowledge, all these sorts of things going on now, as you're saying. Yay. Can we have more? Of course. But people are definitely talking a lot about not being able to get in to see a doctor, or struggling or what. And so maybe we can shed some light on what's happening when we're arriving at the doctor's office. Like where are we getting lost in translation with, I come to you, a doctor, and then, I walk out there maybe misunderstood, because a lot of what you're doing is maybe relying on what I'm bringing to you, I would imagine.
Yeah, it's a good question. And I think there's multiple reasons. Like one is sort of similar to my picture, right? Like I didn't know what was normal. So sometimes when we don't have those conversations or have a baseline understanding of what a menstrual cycle is supposed to look like, we don't get care for it. Number two, oftentimes, and sometimes there is in the Canadian healthcare system, as you know, at the very least, this short period of time that you can see a family doctor, right? Like, and the family doctor sometimes doesn't even verbalize what they think is happening. They're going to take all the information and be like, here's birth control. And they're doing that because birth control pill will decrease circulating testosterone, and it will decrease the risk of endometrial hyperplasia by giving you a bleed regularly, right? So that's a treatment for PCOS, especially if you're not fertility track and perhaps also looking for contraception. And that is, lots and lots of data on it at the end of the day as well. So oftentimes people don't know that they have PCOS, and that's why they got on that. That's why they were given the birth control pill, and then it was managing their symptoms. And when they come off it, either because they want to come off it or because now they're thinking about having a family, they're like, oh, I haven't had my period in 4 months, or I am again having difficulty getting pregnant, or XYZ, right? So there's that component of it. And then there's also, like, sometimes PCOS can be well managed, right? Like, let's say you had irregular cycles, you go online and then now you read that, oh, a little bit of weight loss and a little bit of an exercise should be done for PCOS. Sometimes you manage it on your own and then life happens, and then that's when symptoms show up. There's just so many different things that are happening at the same time. But if you are someone who's going to your doctor's office, I think, like, what you really need to communicate, and you can really do this in a short period of time, is track your cycles, track your symptoms, and say it all in one sentence. Take someone with you if you need to, and even pose a question. Do you think I have PCOS? Right? Like, I get a lot of patients who are like, do I have PCOS? And some of it is because they don't have an understanding of PCOS, right? Like, it is super common and they see it out in the world, but they have nothing close to PCOS. Their cycles are regular. They don't have acne, but sometimes they have ovarian cysts, right? Like, sometimes the ovarian cysts, they're like, oh, I have like 3 ovarian cysts, and that's polycystic, if you think about, like, the term quite literally.
Yeah.
So yeah, I think there's also, like, a communication problem when it comes to how medical professionals communicate sometimes. Because I have patients all the time who are like, oh, my doctor, I reached back out to my doctor and asked them about, like, when I went on birth control pill, and they said that, oh yeah, you have PCOS, and the patient's like, I never knew that, because it was never said out loud to me, right? Like, it was in the chart, but even if it was said, they forgot, right? Like,
yeah, it's a lot of information.
About age appropriate education too. Like, sometimes when you're young, that extra information is irrelevant to you because, like, the context is different, but as you age, it becomes more relevant, and that's when we have zero education or information.
And it makes so much sense why a lot of women during their fertility process are learning about this, and why we're saying, okay, let's learn from a lot of these women that are going through the hardships right now, and how can we sort of focus on our young kids early on and look for signs. And one of the big gaps that I appreciate you help fill in this part of this conversation is it's a link. Your period can be a link to a lot of other contributing factors. So if we start even just tracking our period, then we can maybe show up and fill that gap when we go to the doctor with a little more, a little more information when we're trying to advocate for ourselves. Is there something a lot of our women in our community here, can be doing or thinking about to advocate for themselves so that they can have that clear conversation? So tracking their period and all that, but when they show up, is there something that they can do or say that can help them get on the right track? Because I think it's like you prepare for it and then you show up. What could I say or do to help me in that situation?
Yeah. And again, like, it's going to be a little bit different based on what you're going in with. If we're talking about PCOS specifically, then I think and here's where I think family doctors could do a better job is, right, like, ask questions about menstrual cycles, which is not part of routine checkups. We exist in sort of this reactive kind of medical model, right? Like, if something happens, then we go. Whereas we know that when it comes to menstrual cycles and hormones and most conditions that can be even prevented, like heart disease, let's say, then the proactive conversations really are what are helpful, because heart disease, going back to that topic, super relevant for PCOS as well, is still the leading killer even of women, right? Like we focus on breast cancer, but breast cancer kills less women than heart disease at the end of the day. And we need to have these proactive conversations about it.
And we
But
have
when
high numbers, sorry to interrupt, but in our South
Yeah.
Asian community for our women, and our men, we have such high numbers, higher, they would even say, when compared to like other, like white women even. And so I think a lot of that, well, maybe we'll talk a little bit about that, but it's good to be curious about where all that's coming from. And again, how to, if we flash forward to our little, girl in this story, what are the things we can help her with? So that she can lead a healthier path or have a little more knowledge when it comes to cardiovascular and heart disease and all those things that they're right there
Totally.
in our community, right? They're not going away. So we have such a high chance.
Totally. Yeah, it's very true. And there's lots of, again, like I think there's a lot of missed opportunities at many different levels of everything that play a role there. And same thing with menstrual health, right? Like I think we ask more questions when fertility is on the line, and when it's not on the line, we ask less questions. So I think as individuals, like ultimately, I think, and unfortunately, in many ways, the onus is on us. And again, like when you don't have a good baseline understanding of what normal and abnormal is, then you don't know what to ask. But I think like a good practice always is like track your menstrual cycles. It's always a great place to start, because then you can see, is it regular? Is it irregular? Is my bleeding pattern like semi-consistent from month to month? Am I having debilitating symptoms? Am I having like symptoms that are really getting in the way? I always say if you have symptoms that come and go, that's a great place. Your period app is a great place to put them, because if there's a hormonal link, it'll be there. If there's no hormonal link, it'll be there. And at least you'll have a good record of it, right? Like ultimately, when we look at menstrual cycles or hormonal health, we are looking at trends over time, right? Like a one-off is a one-off. We expect it. We don't really do anything about it. Usually we'll course correct. But if you are going many, many months without a period, then that actually also puts you at risk for endometrial cancer. And that's what we see in PCOS. If like 3 to 4 months is when we want to induce a bleed, if you haven't had a bleed in 3 to 4 months after obviously confirming for a pregnancy if sexually active. So part of it, I think, is having those conversations and asking your medical team those questions, right? And I think we haven't fostered a culture in the medical system to do that, unfortunately, to just like go in and like ask questions about your health. This is what I always tell patients to do. I'm like, if you have questions, write them down. And in my electronic medical record system, I have a place, like I have a portal. I'm like, you plop them in there. I'll pull them up next time we have an appointment, right? Because we forget things too, unfortunately. And we have so many things pulling on our concentration and focus and mind, that I think like writing things down is just the best way to not be super reliant on this. At least I find this of myself. I don't even remember like phone numbers anymore. I like I keep like reciting my parents' phone number every now and again. I'm like, I need to make sure that I don't forget their numbers, because we don't dial them, right?
Totally. Yeah.
So
remember a little while ago we had like a whole blackout. Well, I don't know. Sorry, here in Calgary we had some kind of like little blackout, and we couldn't have access. And I remember I was still working, and we're trying to figure out exactly that was like how to get in touch with people. And yeah, but apart from maybe 2-3 phone numbers, I couldn't say I remember them all. So good point with writing it down.
Yeah, for sure. And then asking the question that, hey, do you have an idea of what I may have, or what further testing that we can do, or what can I do on my end to sort of better understand what's happening with me? What should I be tracking, right? Like I think all of those conversations, and if they can't give you an answer, can I be referred to a specialist? Can we revisit this in X amount of time, X amount of months, to see what's happening, if this is still an issue for me, if we're not going to do anything about it now, right? Like I think asking those questions like straight on is also really helpful, because again, like I said before, sometimes doctors have a differential diagnosis, but they don't say it, because either for whatever reason, right? Like I personally, I would say sometimes I like overshare with patients in terms of like what I think is happening. And I never want to instill fear, right? Like that's not the point, but I do want to plant some seeds in case like I never see them again. I'm like these, and that's where I sometimes come from. I'm like, if I don't ever see you again, like sometimes I think like I want to like lay things out for you just in case you come across this later.
I was just saying, like, I personally think that's also the difference between like a naturopath doctor and like your family doctor. You get a lot more. I mean, your friggin' questionnaire is like 7,000 pages when we sit down, and it's great because you ask questions that do go back generations as well, and looking into some of these things with, your genogram of your parents, your grandparents, and those things. And we don't always ask those questions in the medical field, and we're just starting with a small part. And again, as we're getting to right now, there's a whole bigger picture that's connected to. So while I'm talking about being diagnosed with PCOS, I'm learning in this conversation, holy crap, the bigger picture, the world, all these sorts of, the environment, cultural factors, all these things are playing a factor today. We just talked about fat shaming, that in itself is such a huge barrier in your field, right? And for patients, and none of us are stopping it. We all know it. We all don't like it when people do it to us, but we keep doing it. We keep complimenting, as you said, each other on how we look. You look great. And you're like, thanks. I feel like shit. I had the worst weekend, and it's just stupid conversation, like talking about the weather, but it keeps getting in the way. So can we shift a role of the environment for a second? If you think of little you and, the little girl that we want to help build this healthy future and help teach her about her, hormonal journey, her health. What are some physical and cultural factors, in this health journey that we could sort of consider or pay attention to? Maybe even things that came up for you when you were going through this journey as a little girl.
Yeah, there's layers of factors that if we take any complex and or long-term condition, it's not just one thing, right? Like it's a multitude of factors. So I would encourage anyone listening or watching to really write down your family history, especially of like medical conditions, because like that is sometimes something that, people pass away, people go away all the time, and you want to have a good record of that for yourself and for the future generation as well. I think write it down somewhere so you don't forget, and make sure all your health providers have that in their files. PCOS, we know that there are epigenetics and genetics involved. So genetics are obviously the genes which come down the line from our ancestors. And then there's epigenetics as to how those genes are expressed. So people with PCOS or dysregulated blood sugar, or even elevated levels of androgens like testosterone, for example, like that starts to change the programming of babies in utero, so like in the womb, and that can start to have an impact later on in life in terms of PCOS progression. We're finding that out. And we also know that there are certain what we call genetic polymorphisms, so slight changes or typos in genes essentially that are more prevalent in certain populations than others. And that's why we see like certain kinds of phenotypes or manifestations of disease in certain populations over others, and certain predispositions in like Chilean people versus Indian people versus Iranian people, right? Like depending on who you're looking at and which population you're looking at. So that research is in its infancy, I would say. We don't know what to do about it just yet, but those links are there. And then well,
maybe one thing we can do about it, if I can just add, is I think when again we're exposed to newer information, it's hard to digest it and understand how that could be related to me as a human, let alone the big picture. And I think it's always good for us to just be curious about. Like this, the simplest example I'll give you, it's such a different example. The Super Bowl was the other day. People have all sorts of things to say about the halftime show, right? And, my dad, very different generation. He watched the Super Bowl for the sake of watching sports. And halftime show comes on, whatever. He calls me the next day. And I was really proud because he's like, so what did you think of it? Can I learn a little bit about this? And I thought, oh, look at this. Like, it doesn't matter how old we are at any point in life, we can ask a question versus telling what we think of something, learning about it. Who cares if I liked it or not? What are other people thinking? This is interesting. And so I think sometimes when it comes to new research, we're fearful and we don't know how to accept it. And I would just encourage us to be really, really curious about all the new research that's coming out for a lot of us in our communities where there was a lot of rapid life change and, being kicked out of your environment, being taken out, having to leave, being in survival mode, colonization where your crops are changed, farmers, are doing all sorts of different things with growing food. All those things we don't know everything about, but we are learning. They are impacting us today and how our anatomy functions. And that's as doctor as I will ever be able to be. But, I think we have to just start to fill the gaps in between of how is that information linked to this, to me. So
totally. Yeah.
That's one way we can just, kind of like push ourselves to want to know a little more about that.
Yeah. And I think like that's where I think the ancestry and epigenetics field are sort of coming together, because a lot of the genes that are involved in PCOS, we're finding that they have to do with metabolism and energy conservation and energy production, right? Like, and that's what insulin resistance essentially is. Like, we need glucose to live. Like, that's our cellular energy currency. So, and those are some of the genes that are impacted, apart from like some of the menstrual cycle genes. But even hormonally, when we think about how the menstrual cycle works during times of significant stress, our menstrual cycles aren't the priority. Our reproduction isn't the priority. Survival is. So there's so many interesting things to think about in that respect. But I think like for the average person, what we also need to say, what I like to say, which brings me back to something else I said, is this is not your fault. You know what I mean? Like there's so many layers there. And then let's talk about a few of the other layers is early childhood events, right? Like whether that's trauma, whether that is high stress levels.
Yeah.
Exactly. Attachment, what kind of family you grew up in, your family of origin, financial situation, what kind of foods you had access to, activity levels growing up, especially around puberty, like a lot of hormonal programming around puberty and how that is connected to what's happening in your environment is really critical as to not just PCOS, but also PMS and PMDD. So like those mood disorders we see with menstrual cycle change, right? Like we're starting to paint a broader picture in our menstrual and hormonal health and how that is interacting with the infrastructure, as well as some of the marginalization people experience and the education you have access to. Even when we look at education and healthcare, not only access, but having education actually helps us improve health outcomes because we understand them better. And then we also, I think, automatically start to have a little bit better compassion toward ourselves, right? Like, and then we normalize some of the things that are normal. And then we start to think about the things that are affecting us negatively or symptomatic in a different way. Like all of those things aren't in different silos. They're not
isolated
together.
Yeah, they're all connected. Wow, you said that so well. I love what you said because it's so true. But it's just hard when you live in a world that does isolate all those things and teaches us that one doesn't necessarily connect to the other. And so I think as we're unlearning of that and really trying to re-script it and bringing us to today's conversation, this is why coming out and talking, whether it's in our private friend group chat, with our mothers, whoever, coworkers, just to kind of practice even, feeling comfortable having uncomfortable conversations because they can be life-saving. And I think at the end of the day, that's what it comes down to. It's like we can't be afraid to use our voice for something that we all deserve and we all need, and which is quality of life. And,
Totally.
a lot of that gets in the way
Of talking about the intersection of all of those things because we don't talk about it enough, right? Like I think, and I get why we live in the world of how, right? Like when we're looking at our own personal health care, we're focusing on us, right? Like on the things that we can influence and move toward and how we can make ourselves better for ourselves and for our families. But at a population level, which is also where I like to live, is we do need to explore these relationships to set better infrastructure. And I would arguably say we're moving away from that in this day and age if we look at the political realm right now. And that is going to have a ripple effect, right? Like on people's individual health. And I think we have lots of opportunity to also have compassion for ourselves for the things that we cannot control because it's in the past or it's in our genes or it's in our upbringing, and maybe forgive the people who we sometimes like to blame, right? Like our parents, for example, that you didn't do this or you didn't teach me or you didn't, right? Like I have so much more compassion for my parents as I get older, also understanding that they were immigrants, living a completely different lifestyle in a completely new place, and they did the best they could. And I think that's all we can do too. We do the best we can with what we know now. And then hopefully as we grow and know more, we'll adapt a little bit and then adapt a little bit more and adapt a little bit more.
Absolutely. And I think that's well said. And we should all call our parents and hug them through the phone. I think I do. I think, it's like whatever age it is, I think that's the big coming to of, oh yeah, okay, and I think that's a piece of what I was saying earlier, we're teaching responsibility. Like, what is that? What's mine to own, versus not. And when we're not aware of that, you do take a lot of that on. You do get guilty. And then you do have this fork in this relationship, like you said, with our caregivers, because we don't understand how the past impacts us moving forward. And so childhood attachment, all these sorts of things, they show up. They show up when we're adults and trying to make the sense of our health. And I really like how you put that. So the population that you like to live in, I think that's a good place. So can we go to weight loss for a second? And I know you wanted to talk about some of the social detriments and those sorts of things. And I know this is a place to talk about that. But what would you say is one of the first thing people with PCOS are told when they're, at the doctor's office or a family member or whatnot? Like, what are some of the first things that people are told to do?
Oftentimes people are told to manage their weight, oftentimes without an acknowledgement of any efforts that they have made in the past, or if they have lost any weight, or checking for or screening for an eating disorder. So, and I will shout this from the rooftops, and I think you will too, that eating disorders and disordered eating can happen to anyone at any size. It doesn't matter. So that's one of the first sort of treatment option, because lifestyle intervention is our lifestyle modification is the first line treatment and should be part of all PCOS plans regardless. But I think there is this hyper focus on the weight. And I think because of how society is as well, right? Like we talked about this in our last episode, people really latch on to that as their first and foremost thing to do. And then the other thing that's not really a treatment that comes up is, or it's like more of a comment and something to look out for, is fertility struggles that you might have difficulty getting pregnant. That seed is planted, but nothing is really elaborated upon. And I think what people need to also remember is that as you improve and manage your PCOS overall, those fertility risks also decrease, as in your fertility outcomes should improve with that, because ultimately when you improve your health, you're improving all aspects of it, including fertility and pregnancy and postpartum, right? So I think that's an important one to remember. The birth control pill is another one that comes up often, because and again, like with irregular cycles, and if you aren't looking to get pregnant and you're sexually active, then I would say like contraception is important, because if your cycles are irregular and you're a young person who doesn't have the wherewithal or who doesn't have like the capacity to really focus and work on regulating cycles, the contraceptive can be really helpful to prevent pregnancy, to decrease symptoms like acne, and decrease the risk of endometrial hyperplasia, which is what happens when you don't have cycles regularly for extended periods of time. Then there are other things like metformin that can be used. These days, we're also talking a lot more about, things like Ozempic, like semaglutide. to help with weight loss if that is one of the strategies we're using to help. Because again, mild to moderate weight loss, like 5 to 10% of body weight, can improve all of the symptoms of PCOS and some of the metabolic risks associated with it. But in the same breath, I always say like weight maintenance with body composition change, because we're increasing exercise or improving other lifestyle habits, is still a great place to be, right? Like prevention of weight gain, if someone is gaining weight, let's say, is still a good target to start with. Weight loss doesn't have to be part of everyone's plan. Also, PCOS comes in all shapes and sizes. So weight loss is not appropriate for everybody, right? So I think there's just layers based, and you pick and choose based on who's sitting in front of you and where they are at in life. That's kind of how we have to plan out a treatment strategy, is what are our current goals? Like if they're not fertility track, then cycle regulation is still important, right? Like it's not just for fertility purposes or reproduction that we want a regular menstrual cycle, because a regular menstrual cycle is also telling us that your body is able to coordinate that response between your brain and your ovaries and the rest of you to have this menstrual cycle, right? Like, and if it's not happening, it's because there's something going on that's preventing that. And that is also the thing that is increasing cardiovascular risk in the future, right? Like, so like, it's, even though the symptoms might be XYZ, the way to work on those symptoms is in the background, like on your overall health, and probably a little bit of targeted therapy. So like for hirsutism, for example, or excess hair growth, I would say that's probably the one symptom that is A, super hard to budge, and B, the most frustrating for people. The excess thick, coarse hair growth, right? We're not talking about like the thin vellus hair that we get over here on our arms. We're talking about like thick, coarse hair growth. And again, like there's those layers of self-esteem and how people perceive us and how we perceive ourselves and relate to everything around us. That is part of that. And honestly, like all of it can be really hard.
Yeah, I know, right? It's like you just think of this little girl growing up, and how on one hand, we can prepare for her future by doing the work of being aware to, help her growth cycle, and not have to wait until it's fertility time, a time of excitement and wanting to have babies and all these kinds of things. A lot of women and couples, do in their timeline, and to find out, oh wait, there's all these other things that have been going on. So we talked a little bit of, like, you talked about the metabolic syndrome, so the cardiovascular risk of heart disease, stroke, anything with high blood pressure, anything there that you want to add more or talk about?
Yeah, so screening tests are super important. So your blood work, getting your blood pressure taken, getting your blood sugar checked, cholesterol checked. These are all ways that we catch cardiovascular disease risk sooner rather than later. So if you, regardless of age, especially with PCOS, like cardiovascular disease risk screening is actually like the international guidelines really recommend it. And then if you're fertility track, then what you want to do is actually something called an OGTT, or an oral glucose tolerance test, which is when you drink that not that great sugary drink, and then you have a common pregnancy test, right?
Yes,
to test for gestational diabetes. But if you have dysregulated blood sugar before pregnancy, or before you get pregnant, then that's the time we actually work on it, because it will improve your pregnancy outcomes and decrease the risk of gestational diabetes and preeclampsia and gestational hypertension that is common with PCOS. So early screening is really important, and even postpartum, right? Like postpartum is the time where oftentimes people are missed. And if you had gestational diabetes or if you have PCOS, really in the year after you give birth, you should be tested again with that OGTT. And then around menopause is typically when people are going to see an increase in cardiovascular disease risk slightly, because that is usually when a lot of things show up, even if you don't have PCOS. But you're looking for hypertension, so high blood pressure, you're looking for changes in cholesterol. Oftentimes, people start to move less at that point in time as well. So we likely need to have some changes in how you do your day-to-day life, like nutrition, exercise, sleep, stress management, making sure we're on top of your symptom management. And again, then we want to do our screening tests. And if you're seeing signs of dysregulation, at the earliest sign is probably the best time to intervene. And if you need medication, that is not a failure. Like that, I really want to emphasize that. Like we, in the cardiovascular realm, medical realm, the reason why we use a lot of medications sometimes is because they are life-saving. They prevent heart attacks and strokes, which people with PCOS are at higher risk for. So like, I'm not saying we should over-medicate anybody, right? Like, but if it's really unmanaged, and sometimes we have like really strong genetics getting in the way too, right? Like, or that are part of the picture. And sometimes we can't out nutrition, out lifestyle those genetics. And sometimes we do need a little bit of medication to improve your life for the rest of your life. Rounding out that thought. And sometimes like supplements can be really, really helpful. Like there's lots of really lovely supplements that are better or as good as medications when it comes to PCOS management. Some of the times we think that we're overcoming some of those genetic barriers that exist in conversions and enzymes involved in insulin resistance. Like inositol would be the big one, which is like a B vitamin-like compound that helps with blood sugar regulation and improves ovulation rates. So there's lots of avenues to explore. And ultimately, I always say it's not one thing. You likely need to work on like your overall health. And it isn't a sprint, it's a marathon. It's the long game. It's the long run. You'll always have to do it. And with someone with a condition, you likely will need to do just a little bit more than someone without that condition or without that predisposition, right? Like I used to feel, I'm like, oh my gosh, I have acne and like my cousin can eat whatever she wants and she has like clear skin. It's not because of like something I was eating. That's my genetics. I have such a strong history of PCOS and cystic nodular acne. You know what I mean? Like, and sometimes we put that on ourselves. So I'll come back to that self-blaming piece, right? Like, I think
what's wrong with me?
It's hard to shake it off. It's hard to shake off.
Yeah. But you made such a good point earlier about know your history. You know, and I think there's so on so many levels, like on a personal level of know your genogram. So yeah, like your parents' health, your grandparents, is, you know, a couple generations, if we have the privilege to go back and learning that's so helpful to know and maybe prepare. And I think knowing our history as well of, you know, where's our motherland and what's the story that brought us to North America. And, you know, like I said, filling the gaps in between, learning about our food systems, intergenerational health, the bigger picture, because a lot of that is linked, you know, as we've been saying today. So one of the last kind of things I wanted to talk about here is, well, there's two things. One is, so let's spend a little time on mental health. So we talked a little about mood disorders. We talked about even adolescence and PMS. And I know when you and I met up in one of our first episodes, I had talked about in mental health, there's this crossover when you see young girls that are in puberty and the extreme behaviors we would see in the work that I was doing with young people that were living at some of these centers. And there's lots of history, lots of trauma, lots of attachment issues, all sorts of things. But a few of these stories included us not really putting the mental health world, putting our heads together and looking at the biological world and how those two things can go hand in hand. And so I'd love to talk a little bit about that with you right now. Is just so, you know, as we're dealing with PCOS and some of the symptoms, what is it like for some women in day in the life when it comes to some mood issues and mental health struggles? And really maybe this is a part where caregivers and partners that maybe have taken a break can come back and tune in, because this is a part that you really, really need your village around you when you're feeling unstable or maybe not well. And so I'm sure you've had a lot of women come and talk about that, your own experience. So anything you can shed light on or help us understand?
Yeah, so mental health disorders are prevalent, especially like anxiety and depression and body image distress, like self-esteem related mental health issues. They're very common in PCOS. Part of it is, again, like I don't really want to get into like what causes that, because again, it's multifaceted.
So many things, yes.
Yeah, but there are a few things that we can check for and make sure that are in place. So one of them is going to be vitamin D. So vitamin D deficiency is super common with PCOS, and vitamin D deficiency can look like fatigue and general malaise and low mood, right? Like, so there's overlapping symptoms or manifestations of that. Iron deficiency, you can have PCOS and an iron deficiency, and that's going to make the PCOS symptoms sort of feel worse, or it's going to make you feel worse overall. It will also worsen hair loss, for example. And then there's vitamin B12 deficiency that can also exist. And then autoimmune thyroid issues are also common with PCOS, right? Like, so there's the comorbidities that we want to make sure that we're addressing. Because, like, let's say if someone is vitamin D and iron and B12 deficient, and they're complaining of low energy, which is a common complaint with PCOS, then, like, at least, like, if this is the energy they feel well and this is where they are, we can inch them a little bit closer, and that will have an impact on mood as well. And then, like, the eating, disordered eating, irregular eating, caloric restriction, over exercising, right? Like, all of these things ultimately will have a role to play on mood as well. And then if you're having self-esteem issues or fertility struggles, and there's layers of that. So I think reaching out to your support systems, but also understanding, like, some of it is physiological, some of it might even be cyclical, right? Like, if you have PMS, that is concomitant, because you can have PMS and PCOS at the same time, right? You can have PMDD and PCOS at the same time. You can have endometriosis and PCOS at the same time. You can have many conditions at the same time. IBS and PCOS also, there's a link there. You can have a higher prevalence of IBS, right? Like, so there's all these different layers that can be involved. And then, like, day-to-day life, stress management. So stress management needs to be part of the picture. Social support and community care needs to be the support. Education, and, like, I would say, like, almost continuing education. I know that's, like, more of a term we use, like, for professional development, but, like, ongoing education, I guess, is also part of that. And then exploring, like, our own bodies and relationship with PCOS and really our menstrual cycles and our hormones and our changing bodies. Because, again, like, once you sort of, I feel like a lot of people, when they get a handle of their menstrual cycles, then they're in perimenopause, and because they're in their 40s, and then it's like a whole new ball game, and then you're in your 50s and you're stopped menstruating. So you're all, and that's kind of, I think, what living, like, any condition or just living in your body is like. You're constantly learning new things and adapting to the dynamic nature of life. And that's not an abnormal thing, it's just a thing. And I think, like, part of it is, like, it's hard to do that because there's just so much change all the time.
Yeah, for sure.
But yeah, definitely, like, also sharing your experience with the people you live with. And I think this is where communication and having those uncomfortable conversations really is important. Unfortunately, I also know lots of people who have these conversations with their partners, for example, are body shaming them. And they've brought it up that, hey, you're like, this really affects me. And, you know, what else they need to say. And it continues on. And that's really hard. And I don't even know, like, how we tackle that whole situation, right?
Well,
like,
because to friggin' stop, first of all. Like, give me the number to that person's house. I'll go there right now. Honestly, though, but that's why we talk, right? Because then, like you said a few times today, sometimes you are in the middle of something and it's so normal to you and you don't really realize that it's actually not normal. And that can be for severe things like being in an abusive relationship. That can be all sorts of health issues that we're doing. And so I think part of this journey, as you've been saying, is talking. The more we openly have a conversation or challenge it, you know, if people are, you know, in just as a joke, fat shaming or those things, like, I think we just have to remind ourselves, like, there's just no room for this because it's one tiny joke to you today, but all the undoing that it takes for so many people sitting in that room is not just a little joke. And I have heard from a lot of young South Asian women too, who, you know, are kind of in that cusp of quote unquote family pressure of finding a life mate, you know, let's get married. And, you know, if they don't look like the Bollywood, you know, weight woman, then they're fat and they're not going to get married. And it's just so simple, right? You're just fat. And that's it. And I think we have to push back on that. And my mom lets me push back on that. And she's a generation that would struggle to get that. And maybe it takes 7 times, 8 times for us to have the same conversation, but this is why we can't stop, because it is impacting people more than it is funny as a joke.
Totally.
So,
And as you know, South Asian people of South Asian descent have one of the worst mental health uptake, right? Like, or just even acknowledgement. And I think this is what we see as well, right? Like in your work, I know you've seen it, and I've definitely seen it as well. And we have stats, like even ChemH published a report not that long ago from the last few years that really highlighted that. And I think that is part of the issue, right? Like we oftentimes shy away from having the difficult conversations. And you're right, we need to have them. And then I would encourage people who need extra support, like counseling, therapy, right? Like it can be difficult. It can also be really costly. And that's, I think, a barrier for a lot of people. But it is important to have these conversations, even in a community setting, right? Like you said, when we talk to other people, we open up doors not just for ourselves, but for other people as well. Yeah. Everything that is up in here, other people are experiencing it too. It might not be everyone else, but like a lot of other people. And the only way we figure that out is by talking more and more. And I feel such privilege when I think about this, like all the bodies that I've seen in my practice and the different kinds of bodies. It has helped me to normalize so many things that I thought were not normal, right? Like, because if we think about how we grew up, especially before social media, we saw like a certain kind of person with certain kind of skin and with no hair, you know what I mean? And no weight.
So we saw white chicks, the Euro look, right? Blonde hair, no, and when there was hair, it was okay because it was blonde. Even though some of the girls that I grew up with, we would laugh, be like, "You're way hairier than I am," but because ours looked the way it did. And so these are all things that scaffold and add up. And we all say we turn out fine, and I'm so sick of that line because it's so not true. And I think it's a mask. And we're functioning and we're surviving because we're built to, given our histories. Like, we're gonna be fine. Given what our ancestors have endured, but we want to not live in a fine kind of mentality. It's actually not healthy in that sort of way. So I like you and I were sort of preparing for this even, and when I go back and I look at some of the research too, it's interesting because there is stat. I was like, okay, what Canadian researchers or somebody had reached out when they knew that you were coming, and there's few people had reached out and really excited and had given some suggestions about what we can talk about. And one of them had said, in the States, there's lots of talk about women of color now, or more talk in women's health issues. But in Canada, not very much. And so I was like, oh, okay, let me go and look at this. And it's interesting because, as I was saying to you, in 2021, we had like almost $14 million allocated to women's health studies. And some of that was supposed to be allocated to like women of color because we are made up in different ways. And we have different, like we said, histories that have made us up. And appreciate that recognition. But I think our conversations today are going to help a lot of, research and money go to our needs when we speak up, because when you look at some of these studies that are happening, it's really hard to tell who's really doing it. Is it people of color? Is it with people of color? And like you had said earlier today before recording, a lot of our community, right? This is such a stigma. And so like, who's going to put their hand up and volunteer to be part of a research study, let alone even be in that place when they have no idea something may even be going on. So there's lots of reasons why the data is skewed or why there's not data. And so we continue to have these talks to build up that data so people will be able to, compile the conversations, do the research studies, and, like have doctors like you that are so committed to not stopping the conversation. I think this is really why we're doing this. So there's money out there, but it's not really going to some of the needs that we have. And I think we have to kind of keep talking and pushing for it, right? So
totally. So I don't know if you want also playing a little bit of catch up when it comes to menstrual cycle and hormone research, right? Like,
yes.
We stopped doing research for a short period of time, especially like on pregnant people and fertility aged people. I think we are getting there to exploring more diverse populations and more nuance in research and more ways to effectively help people out. It's I think it's still, we have a lot of work to do, but I
Oh,
am
for
very
sure.
happy that we have made, a decent amount of progress. I won't say like we made a ton as I'd like, but I'll take anything that I can get. Like I'm sort of like this and not but like using the word and, right? Like
Yes.
we've come a long way and I'm really happy about that. This is the most we've ever known about menstrual cycles and menstrual health and sexual health and reproductive health and women's health. But we have a long way to go still. And I think the work of all the people who are advocating for it and talking and speaking up and making documentaries, creating art, right? Like all the people, I think like
Yeah.
all those things really, really help. And I will encourage anyone who can bring things up with your local politicians, right? Like they further that down the chain of command or up the chain of command and that can start to influence how money is allocated. So I think like if we push for that a little bit, and I think as descendants of immigrants, sometimes historically we've been afraid to rock the boat too much, right? Like because we're so grateful to be here.
Well, you're gonna get drowned, thrown off the boat if you rocked it. So, like you really didn't, you hid, but sorry, but I'm just like, making it, a distasteful joke. But seriously, you're right. And we still are afraid to rock the boat. You know what I mean? Like my voice, I know, has gotten stronger because I have been able to see women like you, other doctors, other women of color out there, like you said, artists, whoever doing the kind of work they are, being bold, and even women like me who I always say like I'm an average woman, like I'm just your average lady. But where I think I can appreciate my averageness is that there's many of us like that who have the same average thoughts in our head. And so I think that's the whole point of these conversations is just like, oh yeah, I think about that too. You watch a TikTok video and someone puts something so eloquently that you've been writing in your journal for 30 pages and you're like, oh yeah, thank you for that information. So all of this is like you said, is for that, is for the more we see our representation, our people out there, the more confidence we have to say, hey, let me put my hand up and say, how is that helping me? How is that $13.7 million allocated to women's health actually helping South Asian women, other women of color?
And people in like different places too, right? Like rural populations are underrepresented quite often just because of how we recruit people for studies or where we're getting data from, like fertility clinics or hospitals, for example, or other places, or where universities and colleges are, where a lot of research is done as well. So it's very interesting. Oh, and I remembered the thalidomide trials when people got congenital defects from taking the drug thalidomide. There was a discontinuation of menstrual cycle, research in reproductive aged women for a short period of time because of that. I don't really want to call it a scandal, but because of that whole debacle, we did stop researching for a while. So that was also a setback for women's health at the end of the day, right? And there's obviously, we know there's a lot of other systemic factors at play, like the patriarchy. But I think we're playing catch up now, and I think there's so many people really putting in a concerted effort to make that change, which is really exciting.
I agree. And you're one of them. And I want to say,
and you're one of them.
Well, I think we together, get to be part of something bigger. And I think that's what it is at the end of the day, is like we're doing our tiny little part. Maybe mine's a little tinier, but we're doing our little parts just so that we can, I think take the weight off of all the women that have had to carry that load for many of us. So maybe this is a time where I will say, okay, so this was an important conversation as we started, and it'll continue to be an important one. But before we wrap up, is there anything you wish I had asked you today, or something you want to go back and add to clarify?
I'm really glad where this went. I always appreciate talking to you. I feel like your brain is kind of similar to mine, and it goes in like different directions. Yeah. I'm sure there's lots more to say, but we can talk about it another time.
Yeah, I know, because you'll be back more and more times. Okay, then if you don't have anything to add, why don't you tell us what you want to put your middle fingers up to?
I want to put my middle fingers up to something I already have said before today, which is victim blaming in complex and chronic long-term conditions, because there's not one root cause. It is a multitude of factors, some that are within your control and some that are without your control. And the victim blaming helps nobody. So I'm going to put my middle fingers up to victim blaming in general and a lack of self-compassion for all of that that's like involved in that. Does that make sense?
It really did. Yeah. So it's not, this is my fault. I brought this on. I've done something wrong. I'm a terrible person. I guess I just have to live like this. This is my life now. There's more to that. We can kind of shift that conversation to not it being so closed-minded. So I think that's why we're doing this, is to help those in our lives and those that we know that, when we get to that place, it's a hopeless state. So, glad people like you have that hope to carry and say, we don't have to live like that. We don't have to think like that.
I think we can acknowledge our past and where we come from, right? Like, because I think there does need to be that acknowledgement as well. And we don't want to use it as an excuse either, right? Like, we want to acknowledge it, hold it.
I can't wait for the day when it can be used as an excuse. We're not even there yet. We're not even, our own people aren't even acknowledging. And then there's people like me that are only learning, that grew up not knowing any of this information. You know what I mean? This is your world you grew up in and you know nothing about, or not enough about it. That's another conversation for us to have. So I agree with you. Like, let's just all if you don't want to have self-compassion, then have compassion for the woman next to you and she'll have compassion for you. But I think we just have to, I agree with you. Like, we have to start somewhere, and some people are further ahead than us in other ways. And that's okay. Like, today, if you joined us and you're like, okay, I'm going to go to my doctor, I'm going to look a little more into like some of these discomforts I'm experiencing. Or if you're a partner, you're like, you know what, I'm going to step it up and, check in with my partner about some of the health issues she's struggling with, or, your little kid, whatever it might be. I think there's so many things that we can at least take one thing out of this. So, and maybe that's where you can tell us if there was one thing and only one thing people were going to take from today, what would you hope that one thing would be?
I'm going to stick with this line of thought. You can acknowledge where you come from, but still have lots of influence over your current and future health by focusing on the day-to-day and not getting caught up, especially in today's day and age, and like the shiny objects that come up, and stick with like the basics first. And that's, I think, what I will leave that as. Yeah, especially when it comes to like, again, bringing it back to PCOS. Yes, there's lots of different factors that led to the development of PCOS, but there is lots we can do, and we acknowledge that past, and then we focus on what we can do from where you are at, and it is going to change over time. And I think like that's sometimes difficult for our brains to handle, but it will change over time, and you'll change over time, and that's the reality all of us are living with.
Yeah. Okay, lastly, if you were to go back to that little you that you shared with us today, if you were to go back today and go tell her something, what would you want to go tell her?
Ooh, good question. What would I want to tell her? I want to tell her lots of things.
Yeah.
Like, start exercising sooner, because it's, it's good for you.
Yeah.
That's the first thing that came to mind. So maybe I'll leave it there. Start exercising more regularly. And be kinder to like, think more kindly about your parents. They went through a lot. I think that's the other thing. I think, like, I don't know, sometimes, when you get older, like, some of those lessons come with age and expanding your horizons and perspectives. So I don't know if like little Anne would understand that as deeply as I would, but I would say it anyway.
Yeah, totally. You go back and you tell her that. Okay. As we said in this conversation, and others are having outside of this one, PCOS is more than just weight. It is a complex hormonal and metabolic condition. Women of color, our South Asian women's, we know we need better research and care to help treat this, diagnosis. And I just want to say, you all have the right to advocate for yourself. You have the right to ask questions. You have the right to push for testing. And you have the right to seek racially competent providers. Maybe you need to go see someone that understands your culture, maybe understands your history, where you're coming from, and that's okay, whether that's in the mental health world or in the doctor world. And for anyone listening who this conversation resonated with, I just hope some of this is a reminder that you're not alone. You deserve answers. These conversations are door openers to help us find some of those answers. So this isn't just a Dr. Ann and Kieran conversation. We would love to hear from you guys. Tell us, your journey, your story, maybe some feedback. Dr. Ann, if people want to reach out to you, learn more about you, you share such cool stuff, like I said earlier, on your social media page. Where can they get in touch with you?
Well, I'm fairly active on Instagram. My handle is at Dr. for doctor .Anne, ANNE, Hussain, HUSSAIN. My website has a few resources. It's annhussain.com. And then my book is a great resource for anyone who wants to learn about periods and really like a lot of the things that we talked about, not just the physiological things, but also like the environmental and world and political things, and obviously actionable steps that anyone can take for their menstrual and hormonal health. And that book is called the Period Literacy Handbook, available in paperback and ebook. And I'm recording the audiobook right now.
Oh, that's awesome. That's great. I love that. Thank you, Dr. Ann, for being here. Thank you to everyone else that listened, watched. If you found this conversation helpful, please share it with someone who you might think might need to hear it or watch it. Thank you again.
Thanks for having me.